Okay.
Okay. Okay. When the patient is come, like it can be 1 year old, 2 years old, 6 months old, 5 years, 10 years, when there is a fever, fits, unconsciousness, always there is a few differential diagnoses. Yes, it can be cerebral malaria, it can be meningitis, it can be encephalitis, it can be febrile seizures. So we have to take the detailed history and examination. It's a common, you come across in the pediatric, in the adults, when the patient, there is a fever, unconsciousness, fits. So you have to go in detailed history and examination. Either there is a patient have anemia, the patient have a jaundice, or the patient have a signs of meningitis is there or not, and what is the GCS status of the patients. So we have to go into the detailed history and the examination. So when when think for the cerebral malaria, we have to think for another differential diagnosis. Like it can be possible that the patient have a febrile seizures, like patient develop the fever, fits, and what are the common age of the febrile seizures? 3 months to 5 years. And if the patient come like fever and fits, there's a patient is not unconscious and is active going on, and there is no signs of meditation. So we are thinking for febrile seizures. So when there is a first febrile seizures and there is a fever of fits, there's no other signs of CNS involvement. Age is 3 months to 5 years. We have to go first lumbar puncture because it rule out the meningitis. So if it is CSF is normal, patient is rousable, conscious, and there is a only fever and fits, CSF normal, then we label as a febrile seizures. Because it's a common, you have to label and counsel the family regarding the febrile seizures. It can be from 3 months to 5 years, and there is a chances for recurrence for febrile seizures. Second differential diagnosis is the pyogenic meningitis. Like patient come with the fever, fits, unconsciousness, there will be signs of meningeal irritation will be positive, like neck stiffness will be there, cardiac signs and bruises signs will be there. One or out of these three is there, then and patient sometime may be conscious or sometime may be unconscious. Like patient, if there is only meningeal involvement, patient will be conscious, like only signs of meditation will be there. But if the patient have a pyogenic meningoencephalitis, like brain is involved with the meninges, then yes, there can be patient will be unconscious, and with the signs of meditation will be positive, and we go for the CSF, there will be turbid and abnormal CSF will be, protein will be increased and neutrophils predominant will be there, and glucose will be low in the CSF-DR, and culture will tell the organism. Then regarding another differential is the viral encephalitis. Viral encephalitis, like yes, there will be fever, abnormal behavior will be there, and patient have unconscious or coma. So we'll go for the, and sometime they may or may not have a signs of meditation will be negative, and go for the CSF. CSF protein will be normal, cells will be not as high as like in the pyogenic meningitis, and predominant lymphocytes will be there, and sugar will be normal in the CSF-DR. So we have to meningitis and encephalitis, we will to differentiate only by the CSF-DR. Then fourth differential diagnosis with the cerebral malaria is the hepatic coma. Like the patient come with the fever, unconsciousness, and we have to take the detailed history. If there is a jaundice in the history is there, that is easy to diagnose. If not, then we have to go the examination. Patient will be, jaundice will be there. Like we know that jaundice can be in the cerebral malaria, in the malaria jaundice there. So we have to go for the supportive by the investigation. Like in the hepatic coma, LFT will be deranged, coagulation defect will be PTA, PTD will be deranged, albumin will be decreased. So synthetic function of the liver will be disturbed. So albumin decrease, PTA, PTD deranged, LFT will be, SGBT will be very high. So patient if is SGBT high with the unconscious, then we have to label as hepatic coma or hepatic encephalopathy. Then there is a hypoglycemic coma, like it can be in the cerebral malaria, malaria or in any other disease where sugar will be less than 40 milligram. Then uremia or uremic encephalopathy patient can be fever with the UTI, fever, unconsciousness. Then we have to go into the history, like can be previous history of the UTI, renal stones there, Our patient acute history of vomiting, diarrhea, patient develop that severe dehydration, and patient go into the pre-renal renal failure. Then uremic encephalopathy can be developed. So we have to go into the then examination. The patient have a acidotic breathing, patient have edema, and patient will be blood pressure will be high in the uremic encephalopathy. So these are the some difference points in the regarding the meningitis, encephalitis, hepatic coma, uremic encephalopathy. Then what are the diagnostic criteria? Like we have to detailed discuss regarding the differential diagnosis, hepatic coma, encephalopathy, meningitis, encephalitis. But there are some points when we have to examine the patient regarding that we are suspecting cerebral malaria. Like in the CNS, what are points that we label that first diagnosis is the cerebral malaria, not meningitis and encephalitis. The patient have a with a fever, patient is unarousable or coma more than half an hour. There is a focal or generalized fits, and if there is a posture is opposthetic posture with can be with opposthetic patient have a decorticate or decerebrate. Decorticate like this patient can have a posture upper limb decorticate. Decerebrate that extension of the arms. And in decorticate patient have a flexion with the upper arms, and decerebrate patient have a posture change with the flexion extension with the arms. So we have to look for the examine the patient if they have a posture have changed, and then eyes, that conjugate deviation of eyes is there, and when then again we go for the fundoscopy. With fundoscopy can that if there is a retinal hemorrhage there, then we have to label that yes, there is a chances that patient have a cerebral malaria. Then you go for the renal involvement. If there is a renal involvement, patient have inuria, oliguria, urine output is decreased, like 400 ml per day is there. Our serum creatinine is high, like more than 3 milligram. Then we have to think for the cerebral malaria. Outcome always prognosis regarding cerebral malaria, they have a high mortality, like 10 to 30% patient. If we have to early identify, early treatment, then yes, patient can survive. But sometimes, yes, there is a mortality of 10 to 30%. Then there is the other complication of the malaria, like cerebral malaria. The patient have can be a renal failure, like deposition of hemoglobin, renal tubules, decreased blood flow, acute tubular necrosis are the causes of renal failure. The patient can have a black water fever, like severe hemolysis, hemoglobinuria, and renal failure can be there. Our patients sometimes have a pulmonary edema. It's pulmonary edema. It can be due to the malaria. It can be due to the excessive IV fluid. These are two reasons for the patient develop the pulmonary edema. Patient can have a hypoglycemia, it can be due to the decreased glucose stores. It can be impaired gluconeogenesis. It can be increased energy consumption by the malaria parasite. Patient if the patient on quinine, quinine can lead to the hypoglycemia. Sometimes the patient have a thrombocytopenia or spleen. If the massive splenomegaly, it can be splenic rupture. Another rare complication of the malaria is algid malaria. Algid malaria is the shock malaria, hypotensive shock malaria. It can be due to the infection due to the malaria. Patient have hypothermia, hypotension, rapid weak pulse, shallow breathing, pallor, and vascular collapse. So the patient will be in the dying condition. Shock, hypotensive shock. It's labeled as a algid malaria due to the plasmodium falciparum. Then these were the presentation, clinical manifestation, and complications and differential diagnosis. Then now we have to discuss how we diagnose the malaria. We have to go for the blood CP, complete blood count. It can show that it can be normal, or sometimes can show leukopenia, monocytosis with the normocytic normoclinic anemia. And then we have to go for blood MP. It's a specific test is the blood MP, or we have to go for the ICT malaria. Blood MP will show the thick and thin film. Thick film show that yes, there is a malaria is positive or negative, and thin film show the species, like it's a Plasmodium falciparum, or it's a Maleria, Ovale, or Vivax. Then if we have a differential diagnosis, if the MP is negative, still we have to think for the cerebral malaria, meningitis, we go for the CSF. It will, if it is normal, then think for the cerebral malaria. Electrolytes, we have to know that there is a sub-electrolyte imbalance is there or not. Blood sugar, we have to monitor the patient have hypoglycemia or not. Either we go for the MPR, I said monoclonal antibodies, the ICT malaria test, PCR very rarely. We have to go for first, we only diagnose by the blood MPR, ICT malaria. Then treatment always is a supportive and specific treatment for the malaria and cerebral malaria. If there is a patient have a anemia is there, hemoglobin less than 6, then we must transfuse the patient to save the life. There is hypoglycemia is there, then we have to give 10% dextrose water, and if the patient have a renal failure, we can go for the dialysis. If there is a seizures, then we have to give the diazepam, 0.2 mg per kg per dose, or 2.5 to 5 mg straight. Alternative, we can use the phenobarbital if the fits are not controlled. If there is a high-grade fever, we have to use the paracetamol, or the sponging. We discussed last time how we have to go for the tape water sponging if there is high-grade fever is there. Then fluids, yes, we have to give the maintenance fluids, and if the patient in the shock, then we have to the boluses with the Narmus line, and if it is alleged malaria, we can go for the inotropic support with the dopamine, dopamine we can give. It depends upon the patient condition. Then there is a specific treatment for the Plasmodium falciparum malaria is there. Then we go for the injectable artesunate, the IV or IM. It's an injection Artem with the name of Artem is available, or we can use the IV quinine. There's a two options for the Plasmodium falciparum, because falciparum is chloroquine resistant, so we have to use either artesunate or quinine. Then we have to use tetracycline falcidar. And for the Vivax, Ovale, Maleria, these are sensitive to the chloroquine, so we can use the chloroquine by NG or IV. But nowadays we are using less chloroquine. But yes, if there is a diagnosed Vivax, Ovale, malaria is there, except the falciparum, we can use the chloroquine. Severe cases like patient cannot take orally, and the diagnosis of plasma Vivax, then we can use injectable quinine. And if the patient recover, and then if the patient have Ovale or Vivax, then on the discharge we can use the primaquine. Because Vivax and Ovale, there is a chances for the relapse, because it can Vivax Ovale go into the hepatitis stage in the liver. So we have to kill that hepatitis stage in the liver by the primaquine. So we give the primaquine 14 days to prevent the relapse due to the Plasmodium Vivax and Ovale. But we will not use primaquine in the Plasmodium falciparum. And before using primaquine, it's important you have to know the status of the patient of the G6PD, because primaquine can lead to the patient have a G6PD deficiency, then can lead to the hemolysis. An alternative, if you not use the quinine, then alternative artesunate is another option for the Vivax Ovale or Vivax due to the cerebral malaria. All plasma switch except chloroquine resistant, yes, you can use the chloroquine, and then quinine second option. Then if the plasma is required in chloroquine resistant area, then yes, you have to use quinine plus tetracycline, or some now we are more using that artemether plus lumefantrine with the name of the genome. We can use plus this falcidar with and sometime mefloquine. Then parental drug choice is the quinine again. Then if it is the Vivax Ovale, then primaquine can be used. Then there is many side effects of the drugs that we are using: chloroquine, primaquine, quinine. So we must know about side effects. These more detail in pharmacology. This we have to skip. Yes, now in the end we have to discuss the first that we to prevent that malaria not happen. It's not easy to prevention, but yes, by the government, by ourselves, we can control the malaria by mosquito control measures like environmental control and chemical control. Environmental control, that it can be uh, uh, should be clean environment. It's a difficult in our country, like when there is a rainy season there is always a standing water is there, so there is a more production of the mosquitoes. Then chemical controls, government is trying to control by the DDT, by synthetic insecticides, sprays in the streets, in areas where the malaria is more. Then by self protect against mosquito by the mosquito net, if it is in the hospitals or by rural areas, or where that is more mosquitoes there, screening, repellent, chemical, cream and sprays, and burning coils that can repellent mosquitoes. Like this is well known Mospel that can be used to apply in the night to prevent for the mosquito bite. Thank you. You people are welcome. You have any question regarding malaria? Hello? You can unmute and can ask question one by one. Hello? Any question? Yes? You can unmute and you can ask any question. Ji. Is no question?
Sir, kindly share
No
the
question,
lecture.
Ji, ji. One by one. Hello?
No question, sir.
Okay, thank you.
Thank you, sir.